Did that work okay?
Yep, we've got those slides online.
All right,
Awesome.
good.
And Mike, if you want to go ahead and kick us off, that would be great.
Great. Welcome, everyone. I'm Mike Copenhaver from Allied Health Sciences. It's my pleasure to introduce Dr. Lisa Hightow-Weidman. She is a distinguished and endowed professor in the College of Nursing at Florida State University, and also founding director of the Institute on Digital Health and Innovation at Florida State. She's an expert in the development, implementation, and evaluation of digital health interventions for adolescents and young adults, particularly those with sexual and gender minority status. Her research interests include technology-based HIV prevention and treatment interventions. She particularly incorporates game-based elements, and her work has been to develop technology-based interventions that aim to increase uptake and adherence to biomedical prevention and treatment, increase HIV diagnosis, linkage and retention in care, to ameliorate stigma and increased resilience. She has nearly 200 peer-reviewed articles and a proven track record of successful funding through NIH, HIV/AIDS Bureau, and Centers for Disease Control and Prevention. So please welcome Dr. Hightow-Weidman, and I'll let you take it away. Thank you.
Awesome. Thanks, Mike. I appreciate the introduction and the invitation to speak to you all on, I guess, what is a snowy Thursday? I think it's Thursday. So I'm going to talk about a lot of the work that I've done over the years, particularly focusing on technology-based interventions, and should leave plenty of time for Q&A at the end, and happy to chat more. All right. So again, this crowd doesn't need to be reminded of the persistent HIV epidemic among youth, and the disproportionate impact on communities of color, trans, and SGM youth, and the fact that there's sort of multi-level individual, interpersonal, community, and structural influences that impact engagement in HIV prevention and care. About 20% of new diagnoses in 2021 were among those who were aged 13 to 24, which is the population we'll focus on when we talk about adolescents and young adults. And so my interest in using technology started, many years ago, and really because this is where adolescents and young adults live in terms of being online. Nearly all teens in the U.S. have access to a smartphone and are pretty much on it 24/7. And lots of different, websites, social media sites are also, make up, a preponderance of their daily intake of tech. So thinking about how we can utilize these tools to actually bridge the needs that they might have for real world prevention and care through digital engagement. And, when we think about some of the barriers that young people face, obviously HIV stigma, the phobias, homophobia, transphobia, structural racism, lots of misinformation. There is the potential for digital health solutions to bridge some of these gaps, and we think about it in the five A's plus I added one: accessibility, acceptability, appropriateness, affordability, availability, and anonymity. So can we use these tools to bridge the needs and really kind of break down the walls to get young people to engage in prevention and care? And so I'm going to talk a lot about the work that I've done, which is around an app or a platform called HealthMpowerment, but also sprinkle in some of the other work that I've done through the years. My research in working with digital health really started kind of pre mobile health. So when I first started doing it, it was called eHealth, and it was really about developing computer-based interventions. And my work started when we were recognizing that there was an increase in HIV infections among young Black men who have sex with men. And again, that population has been well characterized as extremely vulnerable and at risk for HIV. But in the early 2000s, this was sort of a new group that we were seeing HIV transmission in this young group. And initially, what we were seeing was that these folks were meeting each other on websites. And again, these were, web chat rooms like, gay.com. They were MySpace, other types of websites, kind of pre the development of Facebook, pre Snapchat, pre mobile phones. But my work really sort of progressed to developing initially what was a web-based intervention called HealthMpowerment. And this is, we call it HMP 1.0, because this was, again, a mobile optimized website. It includes some social components and a little bit of gamification. The highly interactive feature at the time was when I would log on in the morning, when I would get into the office in the morning, I would log onto the website, and a sign on the website would flicker on that would said the doctor is in. And then when I would log out, sometimes late at night, it would go doctor is out. And that was the most engaging, and I was pretty excited by that feature at the time. And we tested this website in a randomized controlled trial in North Carolina with 474 Black MSM 18 to 30. We focused on both those living with or at risk for HIV, which makes this one of the earlier serostatus neutral interventions. This was pre-PrEP when it was launched. And so we were looking at engagement in condomless anal intercourse. And we found that there were statistically significant reductions in those that received HealthMpowerment compared to an information-only control site. And based on this, the CDC noted that HMP was good evidence for risk reduction in their evidence-based compendium. But we also noticed that folks who used the intervention more had stronger intervention effects. And that's something that's been seen across multiple different studies looking at digital health interventions across multiple domains. So HIV, smoking, weight loss, exercise. Really, if people use the intervention, they tend to get more impact out of it. And when we looked at engagement in HealthMpowerment, we picked 60 minutes as what we thought was required intervention usage. And really that was just chosen to kind of match what we thought would be an in-person dosage for delivery of the intervention. And we found that folks who used it for this period of time had fewer condomless anal intercourse events compared to the control group, and the intervention effect was much stronger again among those who used it for more than 60 minutes. We also looked at more usage of the qualitative pieces of HealthMpowerment, which included a forum. And this is work that was led by a colleague of mine, Jose Bauermeister and Kate Messig, that looked at the conversations in the forum among participants and found that folks whose post challenged stigma were more likely over follow up to engage in care and start art. Those whose posts reflected anticipated stigma were less likely to be in care or have a viral load. And those who had shared experiences of stigma were more likely to report lower ART adherence. So again, showing that not only engagement with the intervention content, but active engagement by engaging in conversations did have impacts on HIV care and continuum outcomes. And then over the 20 years of my career thus far, we've done a lot of apps. Too many apps, so many apps. Many of these apps don't exist anymore, and I'll talk a little bit about kind of my experience with that. But I will kind of give you a little bit of some of the work that we've done to show how what we've learned from some of these other apps has informed where we're going and where we're moving with our HealthMpowerment platform. I'm going to talk a little bit about an app that we developed called Epic Allies. This was a really, I thought, one of the best looking apps that we've developed. It was really meant to be highly gamified, meaning that there was storylines, there was mini games, quizzes, an economy where you could earn coins and tokens for doing things, and even a game where you kind of could work together to increase your score. So a really highly gamified app that was aimed to improve medication adherence and initiation among youth living with HIV. And again, these are just some screenshots. Again, beautiful app. I love this app. I'll just, brain teaser, this app doesn't exist anymore. But it really was beautiful when it was built. And again, you could really move through this kind of world and earn badges to show that streaks and engagement. In terms of our results, again, this will be a kind of a common theme that we did a randomized controlled trial. We with 156 folks, 16 to 24. Both arms actually showed improved viral suppression. And again, the intervention arm, participants who used the app regularly, which we defined as 4 or more days per week, had a higher likelihood of achieving viral suppression. So again, overall, app use declined over time. Those who used the app more had better outcomes. This is another intervention, slightly different. This is an app that was focused on improving self-efficacy to disclose HIV status. This is called Tough Talks. We developed this intervention to basically develop a chat bot that would engage in realistic dialogues and then be accompanied by a suite of activities and informational materials to, again, help MSM disclose their status to their sex partners. It was a modular intervention, again, that had lots of different features. I'll try and show you a little bit of what the AI technology did.
Hey, sexy. I've been kind of down recently. How's your week going? What's up?
So you can see this is a chat bot that was meant to kind of talk with you. We created these avatars based on focus groups where we had people rate different avatars to decide kind of who they would sleep with, who was sort of hot enough, but not so hot that would be out of reach. And we had different settings. And we created the avatars to have different responses to disclosure scenarios. So some with kind of positive results, some with kind of that were really kind of more negative in terms of their response when someone disclosed, and some that were kind of in the middle. I should say we did this pre ChatGPT, pre AI technology. So it was a slightly underwhelming chatbot if you kind of think about what we could have done with the technology that exists today. And we tested this in a study where we had a fully automated AI and then a staff-driven, we call Wizard of Oz, where the staff was able to kind of operate the responses based on the pre-selected responses that the AI could use, but the staff was actually able to choose those. And in this study, we enrolled folks. We followed for 6 months. Again, slight increases in viral suppression among the group that was randomized. And again, we saw improvements in the staff-driven arm compared to the standard of care arm. Again, our conclusions from this is that the hybrid nature may be better in terms of allowing some to have also human interaction. But again, I think the chatbot itself, in kind of looking back on it and seeing the types of chatbots that exist now, with the ability to really have conversations and remember previous conversations and build and learn on those, I think really was a limiting factor in this intervention's efficacy. P3 is another app that we developed. P3 stands for Prepared, Protected, Empowered. This was a comprehensive mobile app, again, aimed to support PrEP adherence, again, had some gamification pieces, an in-app portal for delivery of adherence counseling. That was our P3 plus arm. And we used some behavioral economics in this study. So we had the ability for folks to earn money based on whether or not they used the 3 core features of the app each day, or lose money if they didn't use that feature of the app each day. So basically their bank account was seeded with $90 at the beginning of the trial. If they didn't use the app at all for 3 months, they ended with 0 in their piggy bank. If they used it every day for 3 months, they ended up with $135 in their piggy bank, and they could receive that at the end of the 3 months. We did a 3-arm study, so P3, which was just the app, P3 Plus, which was the app plus adherence counselor coaching delivered in the app. We enrolled 16 to 24-year-old folks who were on PrEP or about to start, and this was done within the Adolescent Medicine Trials Network for HIV Interventions, or the ATN. Our results in this study, again, we found that adherence, which we defined as based on dried blood spot levels consistent with PrEP, use of over 4 days a week, that the combined intervention arms had a higher adherence compared to the standard of care arms. There were slightly higher differences in the P3 plus arm, but not statistically significant. And the app, we did look out at 6 months. So again, the intervention was 3 months, but they could continue to use the app without the behavioral monetary incentives for an additional 3 months. And the results were not maintained. Adherence was about the same in all 3 arms at 6 months. Again, we looked at engagement, and overall engagement in this app was pretty high. Again, a priori, so before the study started, which is something that is, I think, really important when you're doing digital health interventions, is to define what you think engagement should be before the study starts. And we defined high engagement as based on the monetary incentives, meaning that if they ended the study with $90 or more, that meant that they used the app on at least 60 or more days, so about 2 months, which is kind of the average amount of time that the literature shows is needed for habit formation. Again, a lot of the folks, the majority of folks actually were high users. Medium was sort of in that middle, so basically using the app about half of the days, 45 to 59. And low was basically less than 44 days. And what we found was engagement, high versus medium low, was associated with PrEP adherence, but intervention status did not moderate this relationship. So again, similar results that we found in that people who used the app more had better outcomes overall. So what are some key takeaways from a lot of this work? Well, the development of singular apps, particularly singular apps to address singular outcomes along the prevention and care continuum, is highly inefficient and time-consuming and costly. And so, I think innovation, in the early days, you could say in your innovation section of your NIH grant that you were developing an app and you always got, a 1 or 2 because it was new. I think now if you write that, it actually shows kind of a lack of innovation in that, there are, so many apps that have been developed that more innovative is to not recreate the wheel, but to build on what we know, build on what has been built, and to figure out ways to actually have better structures for resource sharing. So really thinking about what are the common elements of our technology-based interventions, resources, creating all of that content, locators, surveys, administrative components, shouldn't have to be redeveloped each time a new app or web concept is proposed. And this shifting of where our resources go can allow us to actually develop novel, innovative components that take advantage of, what is necessarily, what can be better tailored for the population, or new innovative technology or approach to creating that intervention. And that's really kind of where I've shifted over the last, 17 years or so or more. And really, what we have done is not create an iPhone as evidenced by their success versus kind of where we are. But the idea being that, every time a new version of the iPhone comes out, it's still the iPhone. And as features are either kind of beneficial or kind of result in higher user engagement with the iPhone, as evidenced by buying more, those features get iterated on, improved on, or removed. And so some of these features of the iPhone don't exist, but more features that have actually been used, such as the camera or emojis or avatars, continue to be improved upon. And that's really been kind of our model for how we can move forward with our health empowerment platform. Another key takeaway is, while user engagement is often low, there's definitely certain features that seem to be critical for engagement and behavior change. And these features are kind of, we kind of think of kind of the lowest threshold that probably should be included in all digital health interventions to some degree. They don't work for everyone to keep them engaged, but they work for enough people during enough time of intervention usage that they're really kind of a low barrier to kind of include. And this comes from looking at multiple different studies, again, across the US, globally, various different groups, but various, these factors seem to continue to kind of come out as being really important. Tailoring. So, levels of tailoring can vary, but some level of tailoring of your intervention to users is really seen as sort of required. People expect that, particularly from their digital interventions. I think they expect it more and more as the other technologies that they use in their daily lives become more tailored and personalized to them. You can't, get on a website for streaming services such as Netflix, Hulu, Amazon, I don't have them all, without them giving you recommendations as to what you should watch next. And people also have come to kind of expect that level of personalizations. Our ads and our Facebooks or Instagrams, again, they use information somehow, some a little scarily, but they tailor our ads and our information to us. And that's kind of something that is really kind of ingrained in particularly in young people. Inclusion of some push factors, reminders or notifications are sort of a no-brainer in terms of addressing health behaviors. Provision of self-monitoring and feedback, so some way for folks to track and provide and get feedback. Social support or support, again, this can vary in various ways depending on your intervention, but some connection to peers, providers, et cetera. And then inclusion of some level of game-based elements and rewards. And again, the level of this, varies, but something to make these interventions entertaining in some way. And not, feel like you're just, going through the motions. And that is, these have sort of come out as sort of low threshold features that are critical. And so, again, I think when you look at features that are critical, those were features that were critical to engagement, and then looking at features that are critical for efficacy, and a lot of the same things come out. But again, what you see is that interventions that have reminders, again, whether or not they're tailored resources, we know that provision of information is a requirement for behavior change, although not wholly sufficient. So provision of information, activities, skills building, preferentially using multimedia formats. People don't like to read. And so, the quicker you can kind of boil down your information, the more engaging and entertaining, the better. Again, trackers can be through self-monitoring, diaries, EMA, and again, provision of, tailored feedback is the best. And then again, connection to care. So when you combine those two, you can see a lot of the same things that are critical for engagement are also critical for efficacy. And so what we've done is, over the years of developing all of these different apps, we've basically, with each of these apps, figured out and developed these various features that we have kind of merged into what we call Health Empowerment 2.0. So all the different content, reminders, trackers, et cetera, we haven't sort of thrown out, even though the apps that we've developed may not exist. But we've created a repositories and ways to embed those into our focus on this one comprehensive platform called Health Empowerment 2.0. The other key takeaway is around tech and your tech partner. And I think, I've probably spent more hours, more tears, and more frustrations around this, figuring out how to work with tech partners and talk the same language, recognizing that, it's crucial to really have a trusted partner who's invested in the end product as you are. And again, many of the apps that I had worked on were funded on grant funding. And as we all know, grant funding runs out, and there's often lags and delays between your next, your end of your one grant and your start of the next one. Those aren't often able to predict it, despite, best attempts. And so I've had partners who, at the end of a study basically said, we're done. And then to start up again with another grant, they basically require just as much money to kind of restart, which again isn't feasible and isn't the way that our grant process tends to run. I've also had a partner who, for our P3 study, and this is true, I got a call the day before Thanksgiving, while the trial was still recruiting and following people, and we were super excited. And they said, well, just so you know, at the end of the study, we will not be supporting this app anymore as our company is moving in another direction, and we'll be partnering with a pharmaceutical company, and that will be our only client. And so knowing that the app will not exist anymore, even as you're testing it, is disheartening. And so I think really, focusing on companies that are invested, also working with companies that understand why you need to be collecting data. Again, this happened during another one of our studies, our Epic Allies studies, where again they on a monitoring call, they said, oh, well, we just want to let you know that the app stopped collecting data 3 months ago, and we just noticed. Is that a problem? That was a problem. But so again, really thinking about who you're going to work with, and there's lots of different partners. Some work in-house, some are private, but really figuring that out and being really explicit up front about how much money you have, how much time you have, and what the goals are. And so we were lucky enough about 2019, so before COVID, to engage with a group called One Cow Standing. And this was a group that somehow, for some reason, kind of really believed in the mission that we had, and the idea that we could work together to develop this platform, HealthMpowerment, and continue to improve upon it over time. And I said, if you trust me, the grants will come. At the time, we had, I think, two projects using the app. But I said, let's, if we work together, we'll keep building this, and hopefully we can make this, something that would be really a state-of-the-art kind of DHI platform. And so HealthMpowerment 2.0 was sort of born out of that collaboration with One Cow. This is just kind of a list of some of the features. Again, you can see that they align a lot with the features that I mentioned are that we found to be kind of critical for engagement and efficacy. So resources, lots of multimedia content, goal setting ability with reminders, forum for connection, and Ask the Expert, which allows for connections to providers or other members of the staff, different trackers for medications. We call it a love log, which is basically a sex diary, other health trackers, ability to engage with kind of aspects of research like test kits for uploading or ordering test results. And then again, two-way communication portals to allow for kind of hybrid-based interventions where you're going to have either delivery of counseling or other types of messaging. We realized that, again, what we do is research. And so, having some integrations into the app that also make it easier for study implementation was important. So we have, the integration with study timelines and surveys. We use REDCap. And so we can integrate through, study screening and enrollment, and then randomization, REDCap directly to H&P. Incentives, so we use Tango e-gift cards, and so the ability to deliver incentives within the app. Again, another way to try and increase engagement. If people have to go back into the app to collect their incentive, again, maybe they'll also find something else to do. And then again, specimen collection and tracking. Again, we have game-based elements within the app. These are things we're always iterating on and improving. Trying to, leaderboards and in-app rewards. We call it the HMP store. This is for one of our studies called Light, where engagement in the app, you can gain points and then you can redeem them for items. We have avatars that have been used in some studies. So lots of, again, different approaches to increase engagement through gamification. So we currently have 15 active projects using HMP, including a project, I know Roman isn't here today, but Roman and Jeff Wickersham have a project in Malaysia called My Hero, which is an R21 that uses HealthMpowerment. But we have really studies across the US and globally to support various different outcomes. And I would say not just HIV-related outcomes, but really trying to expand to be able to address other things, particularly around mental health, suicide prevention, stigma reduction, and to use the app really as a virtual cohort engagement platform to allow delivery of other interventions, whether they're digital or not, through engagement with a cohort. So I'll just show a little bit overall of HMP. This is the app for EPIC, which is a CDC-focused study that's enrolling folks in the US who are on PrEP.
We are thrilled to show you how participants can use the EPIC app to support their health and wellness journey. Let's get started. The EPIC app caters to all types of PrEP modalities, whether it's daily medication, on-demand doses, or long-acting injectables. Our customizable medication reminders can be linked with a participant's daily activities to ensure consistent adherence, while the Love Log feature helps a participant anticipate sexual encounters and sets up reminders for their on-demand PrEP doses. Even if they're on CAB LA, EPIC can send them gentle reminders for their upcoming appointments. We understand that adherence to a participant's health routine is crucial. That's why the EPIC app allows a participant to track various habits that might influence their PrEP adherence, such as mood, alcohol use, sleep, and more. With tailored adherence tracking and insightful metrics, EPIC raises a participant's awareness and helps them develop self-monitoring habits for consistent health routines. Community support lies at the heart of everything we do in the EPIC app. Participants can join vibrant forum discussions, share their experiences, and participate in engaging polls. We believe in fostering a sense of belonging and encourage peer-to-peer sharing within the app. Knowledge is power, and in the EPIC app, we empower participants with a wide range of educational content on various health topics within the Resource Center. From interactive quizzes to skills-building activities, we provide them with the tools they need to enhance their education and drive positive behavior change. Participants with burning questions or needing professional guidance can connect directly with healthcare providers using EPIC's Ask the Expert feature. They can get the answers they seek, access valuable resources, and make informed decisions about their health journey. In the EPIC app, we believe in making a participant's experience enjoyable and engaging. Participants can personalize their profile with our avatar customization options. From selecting facial features to adding unique accessories, they can express themselves and stay engaged with EPIC. Privacy and security are fundamental to the EPIC app, employing robust safety measures to protect a participant's information. With features like anonymous usernames, password and PIN protection, and automatic app timeout, participants can trust that their data is safe and secure within the app. We are excited for folks to become a part of the EPIC community. EPIC choices lead to EPIC results.
So you can get a sense a little bit of the app. And I'll show you a couple more of the studies where we've used it in. This is a study, HMP Stigma. Again, this was run by a colleague, Jose Bauermeister and Kate Messig. And the focus on this was to enroll folks living with and at risk for HIV. And among the study results are still being analyzed, but at least among the folks who were living with HIV, those in the intervention arm were 2 times more likely to have a consistent undetectable viral load. There was no differences in routine testing among those not living with HIV, But again, increased engagement was associated with more frequent testing. And so many more results to come from this study that ended just earlier this year. This is an ongoing study that I'm leading with colleagues in Chicago, and it's a virtual cohort study. So it's one of the LIGHT, which are the limited interaction cohorts, focused on SGM youth. And in this study, we've enrolled 3,100 youth. And the goal is to basically kind of follow them over time. This just gives you kind of a look at some of the data we collect in terms of the paradata of usage. Again, usage varies. The goal, this isn't really meant to be an intervention where they use the app every day, but we will be randomizing some folks in the later years to intervention delivery through the app. This is another LIGHT study that I'm leading with folks at UCLA. This is focused on folks living with HIV who are not virally suppressed or suboptimally engaged in care. And we currently have about 750 of our 1,000 participants enrolled. And the goal of this app or this intervention is to develop this cohort to look at different features in terms of responses to surveys, both delivered through the app and through REDCap over time to develop some predictive modeling to predict trajectories of viral suppression and care disengagement. So we'll be kind of doing a lot of data collection. We use a methodology called the Speak Up Survey, which is basically like weekly EMA delivered within the app to collect data. Two other studies that are coming down the pipeline around adherence. These are through the Adolescent Trials Network, which I co-lead with Sybil Hosek. And both of these are looking at adherence. One of the studies is called LIPS, which is linking youth to PrEP. And this is about bringing PrEP to folks, kind of the Uber of PrEP. So going and delivering PrEP, whether it's injectable or oral, to folks in the community or at places of their choosing. And the HMP app will be used as kind of a support service between visits. And then our ATM 173 study, which is called FoxyDoxy. And this is a study that's going to be looking at doxycycline prophylaxis for prevention of STIs among assigned female at birth, adolescent, and young adults, looking at on-demand doxypep versus weekly doxypep. And the app will be used to help adherence, but also to characterize sex events, again, to help with on-demand usage. And then just a flavor for kind of some of the other ways that HMP has been used. This is a study that's done by my colleague, Jose Bauermeister, and his colleague, Lily Brown at Penn. And it's really developed to address suicide ideation and to decrease that. And they have incorporated kind of the development of evidence-based strategies around safety planning within the app to really address some of these issues. And that study, I think, is just completed, and results look positive, but have not been disseminated yet. So stay tuned. One of the things with HMP is kind of this ability to adapt it in an accelerated way to enable formative research. Again, particularly in global settings. I think this is kind of where we were with the Malaysia team, was being able to kind of have a fully developed app through an R21, which often is impossible if you're trying to start from scratch and build an app from scratch. Instead, kind of being able to start with our platform allowed them to actually do more tailoring for the context and make more enhancements, sort of get more bang for their buck, so to say, to optimize the features. And we've done a lot of work to try and optimize the app for global settings. While the digital divide is still an issue, mainly in terms of high cost of data and some of the settings around low bandwidth. So we really have tried to make all the features that we can available offline. So all of the medication tracking features are available, and any content that's already been synced to the app is available, and that allows it to refresh when you hit Wi-Fi for new conversations or new added content. These are just some of our global partnerships that we've had with folks. All of these have been with early stage investigators at the time. So being able to, again, provide folks with more fully developed apps to do pilot work or early work within K awards has been something we've prioritized as kind of a mantra of how we're using and deploying the app. And this is just our last study, our latest study that we're doing, which is going to be our largest study and a true implementation science study. This is a partnership with University of Maryland to deploy HMP across 4 countries in Africa, across actually 5 different sites, and to really look at, we're actually deploying 5 different versions of the app, which we call RISE for this study. And we'll be looking at it among a total of 1,500 folks youth living with HIV or at risk for HIV in these different settings, and looking a lot about implementation science in terms of really having the local countries being intimately involved in delivery of the intervention through us training them and then allowing users to continue use of HMP over the full 2-year period. So just kind of where we're going with the app, and it's in these different studies, but recognizing again that sustainability, so the ability to kind of keep this going, it requires money, it requires time, it requires obviously this tech partnership, and so the way we've really have done this in over the last 6 or so years, 5 or 6 years, is by writing lots of different grants, having other people write grants that they use our platform for. But it's a hard model to keep up, and does require a lot of things to be funded over a period of time. But that model does allow the app to build on itself. And so as new features are developed through different grants, we make those part of the platform that then the next team can use. As content is developed, we incorporate it into the platform so that the next group doesn't have to create the same content and can better utilize its resources. But again, our goal is to continue to streamline the process of developing and adapting these interventions, to be able to deliver them, and to really be able to do more with engagement. To date, we haven't done as much with real-time adaptive delivery of interventions. And a lot of our collection of pair data, even though it's been in real time, we really have been analyzing it kind of after the fact. And so, I think the future really demands that we utilize more of the capabilities of these interventions to do things more in real time. And that brings us to kind of our vision. The vision of HMP is to really continue to make HMP a study management platform for researchers to be able to do these, develop and deploy behavior change interventions and effectively manage patients throughout the duration of their trial. So some of these things already exist, but because of our focus over the years has been on the grant funding to launch new interventions, we haven't really had the focused time to optimize all aspects of the platform. And so that brought us to choosing to write a small business grant, which we wrote, which was funded this year. It's a phase 2 SBIR. And this is exciting for us in that we really have 2 years to focus on making the platform better without having to do a trial of enrolling people, following people, and looking at behavior change. So we're really focused on making this a researcher-focused platform so that we can, again, then continue to deploy it and sustain it. And so aim 1 of the platform is really expediting, automating the development process. So really creating kind of self-service researcher-facing tools. So a researcher, who thinks they may want to use the platform can kind of go in, see what the features are, choose what features they might want, explore and poke around with what that might look like. And then if they, use while using the platform, they can actually build a lot of it as for themselves. So having their own a content repository where they can see all the content that's been developed, choose what they want to include, enhance and adapt it as needed, and really be able to kind of plug and play a little bit more, because currently all of this is done on the back end by our team, which is very labor intensive. Again, this cloud-based system, we've already actually have deployed our app to be on a cloud-based system, which gives us access to a lot of the cloud-based tools that AWS has to create these content management systems. And we think that again, will allow us to better incorporate AI recommendation systems and tailored interventions to deliver to participants kind of in the next wave of studies that use our platform. And then a second aim of the SBIR is to basically modernize and extend the administrative portal. This is the portal that researchers and research staff see to be able to see paradata and participant management, again, in more real time to really bring forth the analytics that could allow for researchers to deploy real-time interventions. And so the whole focus, again, of this SBIR is to work directly with researchers who use and develop digital health interventions to create what they would want to see on a dashboard for them to do these types of studies. And again, the goals at the end of the day are to be able to create tools that particularly are relevant for or available for early stage or underrepresented minority investigators who often don't have infrastructure to implement or the money to start from scratch, and again can maybe minimize some of the challenges and complexities that exist already. Things that build off of the lessons learned by folks like myself and many others who have been doing this work for a long time in terms of development and deployment, and can really then focus on giving folks more fully developed platforms that can then launch into what they want to do. Can really exploit new and novel ways to deliver interventions rather than having to start from scratch of developing the digital health infrastructure. So final thoughts. Again, I think my whole career has been really focused on digital health interventions, and I think that they definitely can be effective to address a lot of aspects of HIV prevention and care, as well as obviously other very diverse conditions and populations. But I think still today, engagement, scalability, sustainability is really kind of where we still need significant work, and really thinking about kind of if we're going to kind of move to the next level of being able to reach the folks that need them the most. So again, my hope is that we can at least HMP, which is my platform is one of a few that are folks that are doing this, so that it's not the only one. There's a lot of other researchers that have kind of I think gotten to this point where instead of starting over, they're really building on different platforms. And again, I would highly encourage folks to look at the other work that's being done in the field. But I think that this is really the way that we will be able to develop and truly deploy sustainable interventions to address disparities and enhance public health outcomes. So that's my contact info. We have some time for questions, but if I know we have a hard stop at around 1:30 or so. So if for some reason you have other questions afterwards, feel free to reach out to me anytime and I will respond.